Hi, I'm Brent Shoji. I'm one of the general surgical faculty. I've been asked to talk today about balancing supervision and autonomy with the training. In the old days, as we were training, we trained by the Halstedian method, which was see one, do one, and then teach one. And that's how many of us learned, partly because that's how it was always taught, partly because technology wasn't very good. However, due to widespread concern for declining resident autonomy from changes in the medical education environment, such as Libby Zion, governmental regulations, time of allowing how many shifts you can do at a time, it's affected their preparation for independent practice, and advances in medicine as well and technology have also affected the type of procedures that they can do. Surveys have shown that 23% of graduating surgical residents have felt that they're not fully prepared to practice as an attending surgeon. Other surveys has also shown that 34% of the procedures considered essential by program directors for people to become independent practitioners have a median of less than 5 cases per graduating resident. Consequently, the training today should really be see several. The more ways you could do the same procedure, the better. Do several. Learn how to do the same procedure different ways to become more competent. And then ultimately teach several. Take the best part of each attending's method that you've learned and create your better method to pass on to future generations. So consequently, what is the goal of the supervising physician? Basically, it's what we've learned in medical school. Do no harm to your patients while teaching you technical skills so the trainee can ultimately take care of the patients themselves. However, how do we get there? Well, there are lots of papers written on this topic describing obstacles, suggested residency program educational guidelines, ways to document trainee performance. However, there's no really good consensus on the best way for a supervising physician to train the trainee, with the ultimate goal of autonomy, i.e. no one size fits all. And there are numerous variables, different perceptions, and everything obviously depends on whether you're the supervisor or the trainee, which end of the perspective you're looking at. A brief summary of the major variables affecting surgical training and teaching. Obviously, different types of trainees. Nowadays, during the first year of categorical postgraduate, you can have general surgeons, you could have ear, nose, and throat doctors, urologists, cardiovascular. You can also have radiologists. You could have anesthesia prelims. You also even have people who are just doing a year who've been out in the lab just so that they can get their license. There are different postgraduate levels of trainees, obviously levels 1 through 5, some coming back from the lab who haven't operated in 2 to 3 years. A different experience of the individual trainees during the same year. No year has the same rotations. No rotations necessarily does the same cases that they can be exposed to. Different knowledge base and skill levels. Some people are just better than others. Different attending preferences on how to do the same procedure. This is probably one of the major variables in teaching residents and may also be one of the biggest variables as to why they get confused. An approach that one surgeon will say is the best way to do it may be 180 degrees opposite from the next surgeon. Different attending surgeons have different comfort levels with procedures and with the trainees. This is also another major variable. Some are more willing to let the trainee do a lot, make mistakes, and correct them. Oftentimes, newer attendings are a little bit more nervous, maybe not as experienced in handling a complication, and obviously may not let the trainee do as much. Different patient complexity, different procedural settings, all these will affect the ability to allow a trainee to do more or less. And then there are the usual other areas that can affect what you'll allow the trainee to do, what the patient expects of the attending surgeon, impact of fellowships and minimally invasive surgery diluting the core residency training, requirement for increased case efficiency and decreased length of cases, financial concerns, duty hour restrictions. All these basically lead to different experiences for trainees, different comfort levels, and ultimately may affect their ability to become autonomous. And ultimately, the attending is responsible for the patient outcome. A lot of the trainees don't see their patients in follow-up that they operated on, and that can sometimes cause a problem. They may not get the direct feedback that they did something that had a poor outcome. But there is some good news in all this bad news. Anatomy is fairly consistent. Basic surgical skills are easily mastered with practice. Basic skills allow you to do more complex cases, and technology is easily available to help the trainee learn or the attendings to teach the trainee. Some examples: YouTube videos, internet, simulation labs such as Stratus, which you'll hear about later. Ways to standardize subjective experiences such as the Simple app. Potential videotaping of surgical cases so that they could be reviewed later on to see what they did good and what they did bad. The ultimate goal is that practice makes better, better develops competence, and competence hopefully leads to more autonomy. So my best teaching point that I can probably give and advice is, as a supervising physician, you need to really critically assess the ability of your trainees' strengths and weaknesses. You want to be able to optimize the ways to teach them, since no trainee is the same. You need to critically assess their technical skill levels. What is their basic procedural and anatomic knowledge base? What's their actual past experience with a particular procedure? You need to ask them, have they done any? Have they seen any? Have they really done any, or were they just the third wheel in the room? Also, do they know what kind of complications can happen during the case so that they know what pitfalls to potentially avoid? There are multiple opportunities to assess and teach the trainee during each interaction. Pre-procedural, you can talk while you're scrubbing, getting ready for the case, do a briefing. During the procedure, you want to really provide immediate corrective and constructive interventions and corrections. This is the best way to try to help teach them, show them what's right, what's wrong, how you like to do things, why they're doing something wrong. And then post-procedural debriefing, not just, hey, you did a good job. Really say, this is what you really did well, this is what you really need to work on. You can't assume that the trainee knows what to do, especially if they do not say anything. Silence does not mean knowledge. Silence sometimes means, I hope they'll let me get to do something, and if I don't do something or say something, maybe they'll let me do it. In essence, there's a fine line of balancing being brutally honest with the residents during the times of supervision to correct errors and develop correct technical skills, and yet allowing them to build self-confidence by allowing them to do procedures, make mistakes, and eventually, hopefully, earn the competence to become autonomous and be able to create and teach a new trainee.